Thank you for inviting me to speak. I would like to welcome everyone to my first progress report and to give you an insight about my PhD topic, which is entitled The Value of Digital Technologies in Orthognathic Surgery. To introduce myself, my name is Darius-Valentin Sandu, and I have graduated the Faculty of Dentistry from Grigore Tepopa University of Medicine and Pharmacy from Iași, Romania, and my supervisors are Professor Gabor Gerber and Professor Victor Vlad Costan, and my SMS is Alexander Schulze-Wenning. My vision is to create the best orthognathic surgery outcome by virtual planning, and I can do this by only following my mission, which is to find the best surgical planning approach. About my specific goals, I have two ongoing projects, two meta-analyses, to be more specific. The first project is investigating the effectiveness of patient-specific implants and surgical templates over splints in orthognathic surgery. Just in the year of 2015, 9.1 million orthognathic surgeries were performed worldwide. Moreover, approximately 10,000 surgeries are performed annually in the United States. So this type of surgery is not as rare as you might think, and it represents the surgical repositioning of the jaws designed to correct conditions of the lower face and the jaw. The positioning of the osteotomized bones is usually guided by an occlusal splint. Even though this occlusal splints was considered to be the gold standard for many years, they are associated with several disadvantages. They require a vast experience of the surgeon, they are very time-consuming, and they are inaccurate. To overcome all these disadvantages, new approaches are available, and they are represented by the splintless surgery, which can be done by using either patient-specific implants or surgical templates. Those two devices are quite similar until the osteosynthesis phase, because the patient-specific implants are using a custom or personal osteosynthesis plate, which is the implant itself. But on the other hand, the surgical templates are using conventional plates, so there is still a need of bending the plates intraoperatively. Patient-specific implants have many advantages, but the most important ones are that they indicate the exact osteotomy line and they have a very high accuracy. So our aim is to find the best surgical outcome by orthognathic surgery. We developed a clinical question: what is the best approach to translating the virtual planning to the operating room during orthognathic surgery? In order to answer this question, we use the PICO format. The population is represented by patients undergoing orthognathic surgery, intervention 1 by patient-specific implants, intervention 2 by surgical templates or guides. The comparator is represented by virtually planned occlusal splints. Our main outcome is accuracy, assessed by linear deviation, angular deviation, and global geometric deviation. And we also have some secondary outcomes, such as surgery time, rate of complications, cost effectiveness, patient's quality of life, and satisfaction of the surgeon regarding surgery. So our hypothesis is that patient-specific implants and surgical templates are superior to splints in orthognathic surgery. And by answering our clinical question, we want to improve the surgical outcome for patients undergoing orthognathic surgery. This is our search strategy. We conducted the systematic search on 15th of November on 3 databases, and those are our results. We started off with around 8,500 articles and cut it down to almost 6,000 articles. As for the progress of my first project, we are still working on the title and abstract selection, and so far I have included 157 articles for the next phase. About my second project, the title would be Investigating the Effectiveness of Fully Digital Occlusion Planning over Physical Dental Model Approach in Orthognathic Surgery. So the biggest aim of orthognathic surgery is to correct the occlusal relationship of the patient. Back in 1960, conventional model surgery or plaster cast occlusion was the only way a surgeon could plan the orthognathic surgery ahead, and it was used for many years to establish stable occlusion. So even though this type of planning was used for many years, it is associated with several disadvantages, such as it involves a long clinical and technological algorithm. so it's more prone to errors. Dental casts must be physically stored and they may wear off or break, and the impression-taking process is uncomfortable for the patient. The good news are that there are alternatives, because in the digital era, intraoral scanning and virtual planing are valuable tools. So the use of intraoral scanning in orthognathic surgery has two approaches. We can use the semi-virtual method, which still uses physical models that are digitalized later with an intraoral scanner. So the occlusion is set manually before digitalization. But on the other hand, we have the fully digital method, where the virtual models are recorded directly on the patient with an intraoral scanner. So the occlusion is set virtually after the digitalization. What is the problem? Even if the softwares and the workflow to develop a fully digital occlusion are available, many surgeons still want to use physical models. Fully digital occlusion setup is available tools nowadays, but yet sparsely employed into the current practice. So our aim is to determine if this extra step of fabrication of physical models is still needed. Our clinical question would be, is the fully digital occlusion planning a paradigm shift in the virtual planning of orthognathic surgery? Our population is again represented by patients undergoing orthognathic surgery. Intervention is represented by fully digital occlusion planning. Comparator is represented by dental model approach with the use of either dental casts or 3D printed dental models. And our outcomes are accuracy and reproducibility of the plannings. We hypothesize that fully digital occlusion is more efficient than the physical dental model approach. And by answering this question, we again want to improve the surgical outcome for patients undergoing orthognathic surgery. So as a summary, my planned submission dates are August 2025 for the first project and November 2025 for the second project. And at the end of my presentation, I would like to leave you with my quote: "The future belongs to those who believe in the beauty of their dreams." And I would also like to thank you for your attention.
I have a question regarding your second project. So you said the second outcome would be the reproducibility, and how could we measure it?
Thank you for your question. So the reproducibility is measured by assessing the intra-observer and inter-observer reliability of the plannings. So in order to assess the intra-observer reliability of the plannings, the same clinician is planning the occlusion twice, but with 4 weeks gap in order to avoid the memory bias. And for the inter-observer reproducibility, they are comparing the plannings from both of the clinicians.
Okay, thank you.
Thank you.
Thank you for your presentation. And my question is about your first study, how accuracy is measured.
Thank you very much. So, as I said in the PICO slide, the accuracy is measured by assessing the linear deviation, the angular deviation, and the geometric deviation of the osteotomized bones. The linear deviation is measured in all the 3 axes of the space, so vertical axis, transversal axis, and horizontal axis. And the movements done in the osteotomized bone are measured at some dental landmarks. And they are comparing the position of those dental landmarks preoperatively and postoperatively in order to assess the mean deviation from the virtually planned position. The angular deviation is measured as yaw, pitch, and roll. So the yaw is the rotation of the bone around the horizontal axis. Around the vertical axis. The pitch is the rotation of the bone around the horizontal axis, and the roll is the rotation of the bone around the anteroposterior axis.
Thank you so much.
So I have a question for you. Thank you for your presentation. With regards to your first project, as we saw in the pictures, this is a pretty intense surgery. Are you going to be looking at also the aesthetic aspects? Like, will there be scarring, and how does this affect the patient's
Okay.
psychology?
Thank you very much. This is a really good question. So most of the patients who want or accept to undergo orthognathic surgery are more concerned about their physical appearance. But as I said, the main aim of the orthognathic surgery is not to correct the physical appearance, but to correct the occlusal relationships. Of course, the physical appearance is also important, very important, and in most of the cases is improved, but shouldn't be considered as a failure of a success of the treatment. And this could also be an idea for a next project, like the soft tissue prediction.
Okay, thank you.
I also have a question. You mentioned regarding the first project that the conventional intervention has an accuracy of 2 millimeters, and in magnitude, the virtual planning has an accuracy of 0.4 millimeters. Is this right? I would like to ask, because usually with these projects we have to look not only on statistical significance but clinical significance. Is this difference clinically, would you say it is clinically significant or not?
Yes, thank you for your question. Of course, so clinically it is very significant because even the difference is not too big between the occlusal splints and the patient-specific implants. Taking into consideration that these surgeries are done on the facial bones, and this will further influence the position of the soft tissue, it is really important, like every half of a millimeter or tenth of a millimeter. So yes, clinically it's very important.
Maybe I would suggest that when you discuss your results, maybe be discussed in terms of the orthodontic treatment following the orthognathic surgery, and how this approach affects that orthodontic treatment, if it's shorter or not. Because if you look at the literature, if you look at facial analysis, millimeter, 1.5 millimeter or 2 millimeters has no bearing on aesthetics if you look at a face, images of faces.